Aplastic anemia. Aplastic anemia is a disease in which the patient has peripheral blood pancytopenia, decrease of all blood cell types RBC, WBC, platelets, and hypocellular bone marrow. Aplastic anemia is a disorder characterized by bone marrow aplasia resulting in pancytopenia, insufficient number of RBC, WBC, and platelets. Aplastic anemia is defined by cytopenia, hypocellular bone marrow where normal hematopoietic cells are replaced by fat. Absence of abnormal or malignant cells. Aplastic or hypoplastic anemia bone marrow is depressed or destroyed by a chemical or drug leading to leukopenia and thrombocytopenia, decreased erythrocytes, and decreased leukocytes, or granulocytosis. If left untreated, aplastic anemia is a rare yet life-threatening condition. There is a significant decrease in the blood cell production in the bone marrow, which leads to a deficiency of RBC, WBC, and platelets. Fat cells proliferate to replace the stem cell. When all three cell lines are deficient, patients are said to be pancytopenia. Etiology. The precise etiology is unknown, but it is hypothesized that the body's ATI cell-mediated and inappropriate attack against the bone marrow, resulting in bone marrow aplasia that is markedly reduced hematopoiesis. Therefore, in addition to severe anemia, significant neutropenia and thrombocytopenia that is deficiency of platelet can occur. Destruction of hematopoietic stem cells is thought to be through an immune-mediated mechanism. Aplastic anemia has various etiologic classifications, but it is divided into two major groups. 1. Congenital, chromosomal alterations, heredity aplastic anemia inherited, 20%. Hereditary aplastic anemia is passed down through the genes from parent to child. It is usually diagnosed in childhood and is called as common then acquired aplastic anemia. People who develop hereditary aplastic anemia usually have other genetic or developmental abnormalities. Some of these include Fanconi syndrome, congenital dyskeratosis, megakaryocytic thrombocytopenia, Schwachman-Diamond syndrome. 2. Acquired, 80%. Idiopathic or autoimmune. Acquired can begin any time in life. Caused by chemical agents and chemical toxins, e.g. benzene, insecticides, arsenic, alcohol. Drugs like alkalizing agents, anti-seizure drugs, antimetabolites, antimicrobials, gold. Ionizing radiation, chemotherapy used to treat cancer. Viral and bacterial infections, like hepatitis, parvovirus. Treatments of other autoimmune diseases such as systemic lupus, rheumatoid arthritis. Cytotoxic medications like busulfan. Other medications like epileptic drugs, chloramphenicol. Bone marrow infiltration in diseases such as myeloma or by metastasis. Prevalence. 1-2% are affected in US. Where disease affects all age and races. 300-600 new cases develop each year. More common in developed countries. Substances associated with aplastic anemia. Analgesics. Anti-seizure agents, mefenitoin, trimetadione. Antihistamines. Antimicrobials. Antineoplastic agents, alkylating agents, antitumor antibiotics, antimetabolites. Antithyroid medication. Benzene. Chloramphenicol. Gold compounds. Heavy meals. Hypoglycemic agents. Insecticides. Organic arsenicals. Phenylbutazone. Sulfonamides. Sedatives. Pathophysiology. Due to etiological factors, antigen stimulation will be taking place and it will activate the T cells. TNF-alpha and IFN-gamma levels will be increased, which decrease the level of telomerase and abnormal shelter in the blood. Excess free alpha globin increases the reactive oxygen species that precipitates intracellularly. It also damages the erythroid membrane that destructs the hem, and it leads to the process of ineffective erythropoiesis, which will end up in iron overload, and the person become anemic by hemolysis and erythropoiesis. Increased erythropoietin will expand the erythroid marrow that causes skeletal deformities and extramedullary hematopoiesis. Pathophysiological classification. 1. Anemia due to blood loss. Acute post-hemorrhagic anemia. Anemia due to chronic blood loss. 2. Anemia due to impaired red cell formation. A. Cytoplasmic maturation defects. Deficient heme synthesis iron deficiency anemia. Deficient globin synthesis thalassaemic syndromes. B. Nuclear maturation defects. Vitamin B12 or folic acid deficiency megaloblastic anemia. C. Defect in stem cell proliferation and differentiation. 1. Aplastic anemia. 2. Pure red cell aplasia. D. Bone marrow failure due to system diseases, anemia of chronic disorders. 1. Anemia of inflammation, infection, disseminated malignancy. 2. Anemia in renal disease. 3. Anemia due to endocrine and nutritional deficiencies. 4. Anemia in liver disease. Potential mechanisms. Absence or defective stem cells, stem cell failure, abnormal marrow microenvironment, inhibition by an abnormal clone of hematopoietic cells, immune-mediated suppression of hematopoiesis. It is believed that genetic factors play a role. There is a higher incidence with age 11. Antigen immune mechanism is involved. The latest theory. There is an intensive rearrangement of hematopoietic proliferative capacity, which is consistent with life. The immune mechanism is autoreactive T cell attempt to destroy the abnormal cells, and the clinical cause balance and complication depend on the balance. If the immune mechanism is strong, there will be severe pancytopenia. If not, there will be myelodysplasia. Aplastic anemia is due to stem cell defect and the stem cells fail to proliferate and differentiate. Mechanisms. 1. Autoimmunity. Cytotoxic T cells, which inhibits hematopoiesis, produce interferon Y, pass on CD34 cell apoptosis, anti-infra, stem cells undergo apoptosis and hence stem cells gradually diminish in bone marrow resulting in aplasia of marrow. 2. Stem cell. Marked reduction in number. Aplastic anemia can be congenital or acquired, but most cases are idiopathic, that is without apparent cause. Infections and pregnancy can trigger it, or it may be caused by certain medications, chemicals or radiation damage. Agents that may produce maroaplasia include benzene and benzene derivatives like aeroplane glue, paint remover, dry cleaning solutions. Certain toxic materials such as inorganic arsenic, glycol ethers, plutonium and radon have also been implicated as potential causes. Classification of aplastic anemia. Moderate. Low blood cells count, but not as low as with severe aplastic anemia. Patients may have few or no symptoms and may not recommend treatment and instead may just keep an eye on blood counts. The condition may remain the same for many years. Severe. The growing cells in bone marrow, cellularity, occupy less than 25% of bone marrow. Normal bone marrow has a cellularity of around 118 years. At least two of the following are true. Neutrophil count is less than 500 cells per microliter. Platelet count is less than 20,000 per microliter. Reticulocyte count is less than 20,000 per microliter. Very severe. Neutrophil count is less than 200 per microliter. Blood counts are otherwise like those of someone with severe aplastic anemia. Clinical manifestations. The manifestations of aplastic anemia obtain insidious. Complications resulting from bone marrow failure may occur before the diagnosis is established. Clinical features of patients are due to thrombocytopenia, anemia and neutropenia. The manifestation of aplastic anemia often insidious. Complications resulting from bone marrow failure may occur before the diagnosis is established. Typical complications are infection and symptoms of anemia like fatigue, pallor, exertional dyspnea, palpitations. Purpura, bruising, may develop later and should trigger ACBC and hemolytic evaluation if these were not performed initially. Fatigue, dyspnea. Low-grade fever above 100.4 degrees Fahrenheit. Low neutrophil count susceptible to infection. Risk for septic shock and death. Thrombocytopenia which leads to bleeding. From infections associated with neutropenia like fever, headache, malaise, adventitious breath sounds, abdominal pain, diarrhea, erythema, pain, exudate at wound or sites of invasive procedures. From thrombocytopenia bleeding from gums, nose, GI or GU tracts, purpura, petechiae, ecchymosis. Fever coma bleeding from mucous membrane coma, decreased level of leukocytes, erythrocytes and platelets with aplastic anemia. Splenum valor. Retinal hemorrhages. Lymphadenopathy. Cervical lymphadenopathy. Repeated throat infections. Diagnostic evaluation. In many situations, aplastic anemia occurs when a medicine or chemical is adjusted in toxic amount. Blood peripheral smear with reticular count. Liver function test. Blood lymphocyte dioxybutynin test, BIF test, for chromosome breakage. Bone marrow aspirate and biopsy. A bone marrow aspirate shows an extremely hypoplastic or even aplastic marrow replaced with fat. Iron and erythropoietin levels. CBC and peripheral blood smear show decreased RBC, WBC, platelets, pancytopenia. Bone marrow aspiration and biopsy. Bone marrow is hypocellular or empty with greatly reduced or absent hematopoiesis. Vitamin B12 and folate test. Liver test and viral test. X-ray and CT scan. USG. Bone marrow test to access cellularity. Bone marrow aspiration, fluid. Bone marrow biopsy, tissue. Iron and erythropoietin level. Management. Therapeutic interventions. 1. Improved diet include ascorbic acid, which enhances iron uptake. 2. Supplements iron, vitamin B12, folic acid. 3. Blood transfusion except for polycythemia vera. Treatment of the presenting symptoms with blood transfusion, platelets, intravenous antibiotics. 5. Oxygen as needed. 6. Epogen, procrit, to stimulate bone marrow function, bone marrow transplant, BMT, peripheral blood stem cell transplant, PBSC, immunosuppressive therapy for aplastic anemia. 7. Phyllectomy, iron diet, radioactive phosphorus bisulfan, myelin, polycythemia vera. 8. Removal of causative agent. 9. Urgent hospital admission. 10. Stem cell or brown marrow transplant, admit to hospital for at least 4 weeks to enable regeneration of the bone marrow. 11. Regular blood test screening for non-transplanted patients. It is presumed that the lymphocytes of patients with aplastic anemia destroy the stem cell and consequently impair production of RBC, WBC and platelets. The main goal is to increase the number of healthy cells in blood. Removal of causative agent or toxins, supportive therapy, blood transfusion such as red blood cell and platelet transfusion. Iron chelation to treat iron overload by deferoxamine and deferriprine. Antibiotics to prevent and fight infection. Hematopoietic stem cell transplantation, HSCT, immunosuppressive therapy, ATT, anti-lymphocyte globulin, and cyclosporine. Potentially, those who are younger than 60 years of age, who are otherwise healthy, and who have a compatible donor can be cured of the disease by allogeneic bone marrow transplantation, BMT, or peripheral blood stem cell transplantation, PBSCT. Immunosuppressants prevent the patient's lymphocytes from destroying the stem cells. If relapse occurs, that is, the patient becomes pancytopenic again, reinstitution of the same immunologic agents may induce another remission. Immunosuppressive therapy. Immunosuppressive treatments with cyclosporine, cyclophosphamide, antithymocyte globulin, or antilymphocyte globulin as single treatment or and combinations. A combination of antithymocyte globulin and cyclosporine is used most commonly. Corticosteroids are not very useful as an immunosuppressive agent because patients with aplastic anemia appears particularly susceptible to the development of bone complications from corticosteroids, that is, aseptic necrosis of the head of the femur. Blood transfusion with transfusion of red blood cell and platelets. Death usually is caused by hemorrhage or infection. Androgens, oxymetolone or testosterone in an ANTAT, may stimulate bone marrow regeneration. Significant toxicity encountered. They may be used when other treatments have failed. Supportive treatment includes platelets, RBC transfusions, antibiotics and antifungal. Splenectomy. Bone marrow stimulant. Antibiotics. Antivirals. Corticosteroids, methylprednisolone. Cyclosporine, given alone or with anti-thymocyte or anti-lymphocyte global, these suppress the immune cells responsible for destroying the bone marrow. Complications. 1. Untreated severe aplastic anemia is almost always fatal, generally because of overwhelming infection. Even with treatment, morbidity and mortality caused by infections and bleeding are high. 2. Late complications, even after successful treatment, include clonal hematologic diseases such as paroxysmal nocturnal hemoglobinuria, myelodysplasia and acute myelogenous leukemia. Prevention. Avoid exposure to insecticides, herbicides, organic solvents, toxic chemicals. Nursing care. Administer blood transfusion and anti-infection therapy. For patients on corticosteroids, monitor blood sugars. Nursing assessment. 1. Obtain thorough history that includes medications, past medical history, occupations, hobbies. 2. Monitor for signs of bleeding and infections. 3. History of dietary habits, symptoms and causative agents. 4. Status of skin, mucous membrane and sclera. 5. Baseline vital signs. Nursing diagnosis. Risk for infection related to granulocytopenia secondary to bone marrow aplasia. Risk for injury related to bleeding. Planning implementation. 1. Teach client about dietary modification and medication administration. Food high in iron includes spinach, resins and liver. 2. Collaborate with client to balance rest and activity. 3. Explain the need for prevention of hemorrhage, thrombocytopenia, and phlebotomies for polycythemia vera. 4. Provide post-operative care if splenectomy is performed. Encourage deep breathing and coughing because these actions precipitate pain and may be avoided. Assess for abdominal distension that may reflect hemorrhage. Nursing interventions. Minimizing risk of infection. 1. Care for patient in protected environment while hospitalized. Private room with strict hand washing and avoidance of any contaminants. 2. Encourage good personal hygiene, including daily showering or bath with mild soap, mouth care and perirectal care after using the toilet. 3. Monitor vital signs, including temperature, frequently. Notify healthcare provider of oral temperature of 101 degree F, 38.3 degree C, or higher. 4. Minimize invasive procedures for possible trauma to skin or mucous membrane. 5. Obtain cultures of suspected infected sites or body fluids. Minimizing risk of bleeding. 1. Use only soft toothbrush or toothpick for mouth care and electric razor for shaving. Keep nails short by filing. 2. Avoid iron injection and other invasive procedures. 3. Prevent constipation with stools softeners as prescribed. 4. Restrict activity based on platelet count and active bleeding. 5. Monitor back down for menstruating patient. Avoid use of vaginal tampons. 6. Control bleeding by applying pressure to site, using ice packs and prescribed topical hemostatic agents. 7. Administer blood product replacement as ordered. Monitor for allergic reaction, anaphylaxis and volume overload. Evaluation. Expected outcomes. Remains febrile with no signs and symptoms of infection. Episodes of bleeding rapidly controlled. States dietary sources of iron, folic acid and vitamin B12. Verbalizes understanding of long-term need for therapeutic supervision. Performs activities of daily living. Remains febrile and injury-free. Nursing management. Patients with aplastic anemia are vulnerable to problems related to RBC, WBC and platelet deficiencies. They should be assessed carefully for signs of infection and bleeding. For dyspnea. Nurse the patient in the upright position to maximize lung expansion. Use an integrated approach to concurrently manage both anxiety and breathlessness. Physical demands will be great due to the symptoms of anemia. Care must be taken to assist patients with activities of daily living while promoting independence. For blood transfusion. Caution is required with elderly patients to ensure against overload of the circulatory system. Blood may need to be given more slowly or spaced over 2 days. Monitor fluid balance. Administer erythropoietin if prescribed. This may improve quality of life as hospitalization for blood transfusion will no longer be necessary. Tiredness. Patients can experience tiredness with a slight exertion. Educate patients that tiredness should lessen as the treatment takes effect. Assistance should be given as required. Periods of rest are encouraged. Patients may be debilitated and may need to be on bed rest. Maintain the water score and attend to pressure sore prevention and risk of deep vein thrombosis. Anxiety and depression. Patients may experience lightheadedness and confusion due to hypoxia. Anemia may cause altered body image and loss of normal personal body state, which is replaced by a more dependent life-limiting persona. This can increase anxiety and bring about feelings of depression. Patients need assistance to restore functioning reassurance. Monitoring. Understanding of the condition. Specific management is required in severe cases. Maintaining a safe environment. Patients are susceptible to falls due to symptoms of anemia. Skin integrity is impaired and skin is easily damaged, so must be monitored carefully. Educate patients on the maintenance of body heat and mobilization. Mental attention span is lessened. Time of work and assistance in the home may be required. A social services referral may be required following assessment. Mouth care. Monitor and record any injuries. Patients may experience cracks at the corners of the mouth. Instruction on mouth care and maintenance of nutrition is necessary. Nutritional assessment and guidance. Refer to a dietitian. Reinforcement of essential foods is required. Provide information leaflets. Discharge planning. Ensure patients are safe to go home. Educate patients on self-care, recognition of anemia and medications. Where required, dietetic support is ongoing. Arrange an outpatient appointment. Alternatively, a follow-up appointment can be made. Elderly people or those who struggle with family responsibilities may need social services support in place prior to discharge. Patient education and health maintenance. 1. Teach patient how to minimize risk of infection. A. Wash hands after contact with possible source of infection. B. Immediately cleanse any abrasion or wound of mucous membrane or skin. C. Monitor temperature and report fever or other sign of infection immediately. D. Avoid crowds and people with illness. E. Avoid raw and uncooked foods. F. Use condoms and other safe sex practices. 2. Teach patient how to minimize risk of bleeding. A. Avoid falls or other injury. B. Use electric razor rather than plain razor. C. Use nail clippers or file rather than scissors. D. Avoid blowing nose. E. Use soft toothbrush or toothhead mouth care. F. Use water-soluble lubricants as needed during sexual activity. 3. Advise patient to avoid exposure to potential bone marrow toxins, solvents, spray, paints, pesticides. 4. Teach patient to take only prescribed medications, avoid aspirin and non-steroidal, anti-inflammatory drugs and NSAIDs, which may interfere with platelet function. As some vitamins and herbs may also affect platelet formation, instruct patient to check with physician before using any supplements.